Hello, good morning, everybody, and welcome to today's Insight APSAD webinar. My name is Michelle Taylor, and I am one of the clinical educators here at Insight, and I will be hosting today's webinar. I am joining you today from Meanjin, Brisbane, the home of the Turrbal and the Yagara Nations peoples. At Insight, we wish to acknowledge the traditional custodians and owners throughout Australia, wherever you are. Their continuing connection to land, water, culture, community, and their knowledge and teachings passed down from generation to generation. So we pay respects to elders past and present, and we extend that respect to First Nations peoples who are joining us listening today. So it is my pleasure to introduce you all to Loren Brener. And Loren is an Associate Professor at the Centre of Social Research in Health at the University of New South Wales. And the topic that Loren is going to speak about today is stigma by association among alcohol and other drug and harm reduction workers, implications for workplace outcomes. So just to get us in the space, I'll read the few sentences that Loren has provided us with to give an outline, and then I'll be handing over to Loren so you can hear all of this incredible work that she's gathered together to share with us. So the negative attitudes people hold towards those who use alcohol or other drugs can also affect the people who work with this community, leading to lowered productivity and well-being. The impact of this stigma by association in the AOD and harm reduction sector is particularly significant because workers may have lived experience of AOD use and identify strongly with their client group. This study reports on research examining how stigma by association among health workers in the AOD harm reduction sector relates to workplace outcomes. A secondary aim was to explore how lived experience influences experiences of stigma by association. So without any more from me, I can't wait to hear all that Loren has to share, and I will be monitoring for people's comments and questions. So thank you, Loren.
Thank you so much, Michelle. Thank you for that intro. I think you've outlined some of my research and some of this talk already, but hopefully I can do justice to what you've spoken about. So I just would like to acknowledge that I am on Bidjigal lands today at the beautiful UNSW campus in Kensington, and pay my respects to elders past and present. So today I'm going to talk to you, as Michelle said, primarily on research we've conducted on the impact of stigma in the alcohol and other drug and harm reduction sectors, focusing specifically on stigma by association. And then I'm going to talk about our quantitative study. I'm also going to talk about some qualitative insights we gathered from participants, which I think are particularly interesting for the context in which people joining this webinar probably work. And then I'm also going to outline a little bit of our stigma indicators monitoring project, which is work we do that feeds into the national strategies for bloodborne viruses. All of these reports are on our website, and I've got links to the papers that I'm going to talk about, so you'll be able to access them afterwards. Just in terms of defining stigma, most of you will probably know what stigma is, but just to provide some context, going back to Goffman's original definition of stigma, it is traditionally defined as an attribute that is deeply discrediting, leading an individual or a group to be judged as less worthy, and for that individual or group to have experienced or be experiencing a spoiled identity. Later conceptualizations of stigma also added that stigma is a co-occurrence of labeling, stereotyping, separating, and then status loss and discrimination. And it occurs in a context where social and political and economic economic power is exercised. And those aspects are really important to understanding stigma. Labeling, stereotyping, and separating acts to exclude or diminish the status of people affected by stigma. And stigma acts to limit almost all opportunities in all life domains. It's very difficult to overcome because stigma is embedded within the basic hierarchical social structures and within a society which operates at the crossroads of culture, power, and difference. So we are particularly interested in health-related stigma. And health-related stigma refers to stigma that is specifically targeted at a health condition, such as HIV or hepatitis C, or a feature or behavior identity associated with that health condition, such as injecting drug use. How controllable a stigma is perceived to be. So whether a person is believed to have control of over that stigma often means that the stigma is viewed more harshly. This is often the case with people who inject drugs, or people who use drugs and alcohol, because that behavior is seen to be under the person's control. A person may also receive poorer treatment if they're perceived to not act in ways that conceal or minimize that stigmatized attribute. So if they conform to stereotypes of what we think of when we think of kind of the stereotypical chaotic person who injects drugs, that person is not conforming to a stereotypical, in a way to minimize the stereotyped attribute. People from these disadvantaged and marginal communities, well, we also know that they have or experience intersectional or multiple stigmas very often. And these stigmas are additive and can have a compound negative effect on their health, well-being, and life opportunities. And stigma, as we know, just adds and compounds and deepens health disparities for marginalized and vulnerable groups. So what does that mean for the research that we did? Well, we know that stigma impacts people who use alcohol and other drugs. And there's literature to suggest that stigma by association also exists for people that are associated with family, friends, or working in a sector with other people who are stigmatized. So we decided to look at this concept of stigma by association, which Goffman originally termed courtesy stigma, and look at it amongst health workers working in the alcohol and other drug and harm reduction sector. So I'm going to talk about that. Then I'm going to talk about stigma indicators monitoring projects, specifically in relation to people who inject drugs, and stigma among women who inject drugs. So what is stigma by association? Well, Michelle has outlined some of that. Stigma by association refers to the discrimination or prejudice experienced by individuals who are associated with people who are stigmatized, even if they themselves do not possess the stigmatized attribute or identity. And negative attitudes held towards people who use alcohol and other drugs can affect workers who work in that space and ultimately lead to lower productivity and well-being. And as Michelle rightly said in the beginning, stigma by association, one of the key things is that it's particularly significant with the group of workers who work in the AOD and harm reduction space, because many workers in that space may have lived or living experience of alcohol and other drug use and strongly identify with their client group. And there's similarities across this work and work in the mental health space, which we have also done, and I'm going to outline a little bit of that just as background to this research. So we did some research in the mental health sector where we looked at people who work, at staff who work in mental health facilities, largely non-government NGOs. And what we found is that staff with lived experience in those sectors experience less burnout, actually, related to beliefs around their clients not improving. And people with health professionals who reported having lived experience in that space also had more positive attitudes toward their jobs. But we didn't, in that research, look at stigma by association. So that's what the current research looked at. So the aim of this research was to examine how stigma by association amongst health workers in the AOD and harm reduction sector relates to very important workplace outcomes. And we look specifically at job satisfaction, well-being, burnout, and burnout was related specifically to a concept called client-related burnout, when you perceive your client as not meeting the goals that has been discussed with them in the treatment context, and also intentions to leave the sector. And then we wanted to look at whether having lived or living experience, what does that mean for people? How does it impact experiences of stigma by association for this workforce? And how does it moderate experiences of workplace outcomes? So we conducted an online survey. This was kind of exploratory research. So we used a number of mechanisms to try and recruit this sample and of health workers working in harm reduction and drug and alcohol in Australia. We circulated through various links and through various organizations, and we managed to get a sample of 228 people to complete the survey. So that's a little bit of what the sample looks like. What is interesting about this sample is that of the 228, 146 participants, or 64%, identified as having lived experience of the alcohol or other drug use, and 87 participants, or 38%, identified as having experience of being a service consumer in the AOD sector. So then these are just some of the measures that we looked at. So we looked at which services people came from, how much time they spend in the service, and what kind of work they do. Really, are they in a direct service role or not? And we looked at scores of job satisfaction, workplace well-being, burnout, intention to quit, and stigma by association. For most of these, higher scores would be more positive outcomes or greater stigma by association. So what we found is that health workers employed in alcohol and other drugs and in the harm reduction sectors definitely report experiencing stigma by association based on the client group that they work with. And those who reported experienced more stigma by association experienced poorer workplace well-being, higher reported burnout, and also greater intentions to leave the field. Interestingly enough, experiences of stigma by association were not related to job satisfaction. We did further analysis then with the participants with lived or living experience. And this group, this is really interesting, reported higher levels of job satisfaction and lower intentions to leave the sector. And what that tends to suggest is there's a need to provide particular support for alcohol and other drug staff experiencing stigma by association. It needs to be acknowledged and supported. But over and above that, there needs to be support with people who identify as having lived and living experience, because they are experience higher levels of job satisfactions and are less likely to report intending to leave the sector, which is important because there are always issues of staff retention in any of these sectors that we work with complex and vulnerable clients. What I'm going to present to you now is some of the interesting information that so there were open-ended options in the survey, and of our sample, over 100 people actually wrote in those open option sections, which were exploring either stigma by association or client experiences of living with a stigmatized condition. People wrote much more than we've ever seen in surveys. And I think the quotes that come out may resonate well with the group today. So I'm going to present a number of those quotes that we pulled out of the surveys. So as these participants said, stigma wounds. I do my best to encourage harm reduction, clients to be positive, avoid negativity, and to keep safe. I try to be honest when someone asks me what I do for a job, to try and tackle stigma. The response from the other person tells me a lot about who they are. And then someone else says, stigma is a huge, unwieldy barrier to push through on a daily basis. It's exhausting and so disappointing. So obviously, for that last person, stigma has impacts on their day-to-day functioning in their work environment. And some more quotes. I feel like I have to justify to the public or family that people who use the service that I work for are deserving, good people, and have the right to live their lives using drugs if they choose that. I have become fairly adept at ignoring stigma. If people want to pointedly stigmatize me because of the work I do, then I'm quite happy to disregard their opinions entirely. So that's quite an interesting way that someone has learned to manage stigma within their environment. And as someone else says, I know many peers who have chosen to edit their job title because they don't feel safe being identified as a peer worker in certain spaces. And some other health professionals blame us for the challenging behaviors exhibited by our clients. That was mentioned in different forms by a number of our participants. One AOD worker described witnessing people become ill because a medical professional had deemed them to be drug seeking. Another AOD worker observed that hospital staff can let their own professional biases override their duty of care in treating people who use drugs. And hospitals are a common site, as you would know, of people reporting that they experience stigma and discrimination. A third worker stated, my experiences at work are mostly positive. However, I have to accompany my clients to services with the hospital and community so that they don't get berated. So we also looked at things like structural stigma, which if you recall at the beginning when I gave the definitions, I spoke about how important it is to understand stigma as something that occurs at a political, cultural, and social level as well as a personal level. And that's the thing with stigma. It's quite pervasive and in some areas almost institutionalized. So an example of structural stigma is when an alcohol and other drug service experiences physical, operational, or conceptual separation from the broader health or organization systems that they sit in. And we do sometimes see this with drug and alcohol services, that they sit separately from other services. And as this person says, workers in the broader organization sometimes blame things on our clients, tend to see our clients as a hassle and a program that needs to be separated from other programs, and don't seem to see our clients as worthy of receiving other services. And as this individual who works alone in their organization said, I'm a solo worker in my organization. I have minimal to no management support and no one I really feel I can talk with. I feel very excluded and my mental health has deteriorated since being in this role. So even in circumstances where AOD and harm reduction workers do not feel directly stigmatized, the stigma towards these service providers can still have a negative personal impact on workers. It impedes their ability to be effective in their work, as well as to be positively regarded by others for the work that I do. So as this person wrote in the survey, when the clients I work with are stigmatized, the work they do to better themselves is stigmatized. That includes the work that I do with them. I am not stigmatized as a personal worker. My work effort is stigmatized. I thought there was a really interesting way that this person conceptualized how stigma impacts them in their work environment. So just some concluding comments on this research. So what we concluded from it is that there's a need to provide a more supportive environment for staff, given that they were in the alcohol and other drug sector and harm reduction, sectors, given that they report experiencing stigma by association. This needs to be acknowledged, and it's something I think that often isn't. Even this work we've done has received quite a bit of attention, and so I think it's something that needs to be discussed in the work environment and in other contexts for people to contextualize and be able to create the most productive work environment in the AOD and harm reduction sectors. This work clearly shows that it's linked to poorer workplace well-being, higher burnout, and greater intention to quit the industry. We know the client group that people work with is complex and have histories of disadvantage and trauma. And so some people within the sector have come from that background. And so it's very clear that this workforce should be well supported, particularly because this research is able to show that people with lived and living experience of the sector actually have less negative feelings towards the workplace and lower intentions to leave that work environment. Stigma by association is therefore important to target in developing interventions to decrease burnout and increase staff retention, including a focus on lived or living experience in the health sector. And we know that ultimately increasing positive workplace outcomes for AOD and harm reduction staff will lead to better quality of care for service users. And I think the one thing that isn't outlined here, the other really important thing is that this needs to be addressed at a managerial and structural level, as well as within client-facing, as well as for client-facing staff. So that's the majority of my presentation. I'm going to talk a little bit more about some of the work that we do at the centre, just so that there's kind of an awareness of the other work that we do. This is a national project that we work on. We've been working on it for 5 or 6, maybe 7 years now. And it's a project that feeds into the national strategies for blood-borne virus and sexually transmissible infections, of which one of the key goals is to eliminate the negative impacts of stigma, discrimination, and legal and human rights issues on people's health. Our project, called the Stigma Indicators Monitoring Project, is a project that monitors stigma amongst key priority populations. So for the purpose, we have a number of those key priority populations. For the purposes of this presentation, I'm going to talk about people who inject drugs, and then specifically about women who inject drugs. So I've just pulled out some key questions from our survey. We've done 4 surveys among people who inject drugs. We have a complicated data collection strategy, which involves a network of peer organizations across the country assisting with data collection. And you can see we started out in a kind of exploratory way in 2016. And then we picked up our strategy by 2018 and kind of delayed a bit by COVID and so on. But what you can see here is, in relation to the question, in the last 12 months, have you experienced any stigma or discrimination in relation to injecting drug use? The yellow section is the largest, which is sometimes. And if you add the sometimes, often, and always, that's a pretty large group across the 4 time periods with minimal change, who report experiencing stigma or discrimination in relation to their injecting drug use. Then we asked the question, have health workers treated me negatively or differently to other people? Again, it's the same 4 groups, across the same 4 time periods. And unfortunately, you can see again the yellow section, which is sometimes, is a big section, and especially when added to the often and always sections in this, and again, limited change over time. So people are reporting that health workers have treated them negatively or different as a result of their drug use. We also ask we have other surveys, and in our other surveys, we survey the general public and healthcare workers. We've also been doing this over a number of years. This report's in our most recent data set. So we asked the general public if they would show negative behaviors towards people who inject drugs. We had a sample of 2,251 people. And again, you can see sometimes, often, and always comprise the biggest categories. Unfortunately, it's similar when you look at health workers, which is a separate survey of health workers. And we have almost 50% in the yellow, orangey color, and blue that say that they would behave negatively towards people who inject drugs and they work in the health sector. And then the last question is actually a question that we asked of that health working sample if they had witnessed colleagues behaving negatively towards people who inject drugs. And the numbers are similar, actually slightly less to self-reported negative behaviors towards people who inject drugs, but it's still too high. Obviously, any form of kind of stigma or discrimination is, especially in the health sector, is too much. So just another interesting slide on this topic is that we asked people, and what's really interesting about this research is it's some of the first research to actually show that people who report increased stigma or discrimination, that it's having an impact on their access to healthcare. So you can see here, we asked people in the past 12 months, how often have you done the following to avoid being treated negatively by health services? And again, you can see the high numbers who say they've not told health workers about drug use. They've delayed accessing healthcare. They've not attended a follow-up appointment. They've downplayed their need for pain medication, or they've looked for a different service. So, just to summarize that, finding from the stigma indicators monitoring projects suggests that stigma and discrimination continues to be commonly experienced. There are proportions, quite big proportions, of health workers and the general public who report negative behavior, and there's no discernible change over time. This is in the absence of a national intervention. I mean, we have some intervention work that we've been running at a kind of in a small context, and we have seen change with these interventions, but they aren't sustained over time necessarily, because we need ongoing interventions, and we need these interventions to happen at a national level. And we are currently working on an intervention, but that's a whole separate presentation. So as I've noted, wide-ranging intervention initiatives are needed to reduce stigma and discrimination towards people who inject drugs. And now the last thing I'll talk about quickly is stigma amongst women who inject drugs. So we looked specifically at a subsample of women who completed the stigma indicators monitoring survey. This, I think, is the 2021 survey. And we looked specifically at the group of women who completed it. So women, the surveys, we always have a larger number of men than women who complete the surveys, which kind of is in line with reported injecting practices in the broader community. The mean age of their first injection was just under 21 years, and almost 40% injected daily or more. Only under 20% of the women reported that they had not experienced any stigma or discrimination in the past year in relation to their injecting drug use. So we asked them obviously the same question because it's the same sample. In the past 12 months, have you experienced any stigma or discrimination in relation to your injecting drug use? And it's pretty stark that you have close to 50%, maybe over 50%, who say sometimes, often, and always. Similarly, with health workers treated me negatively or different, the figures are similar to having experienced stigma or discrimination. So women are having negative experiences or difficult experiences when they are going into healthcare systems. This is I think, quite a confronting slide, because we asked those questions of the women, the subsample of women who inject drugs, about actions taken to avoid stigma in the past year. We grouped categories together. So when you look at the sample, there were 266 in this sample. Each of these questions, over 70% of all the sample have taken all of these actions to avoid experiencing stigma or discrimination. So they've delayed accessing healthcare to avoid stigma, did not disclose their drug use to a health worker, downplayed the need for pain medication, looked for alternative services, or did not tender follow-up. And this has occurred within the last 12 months. So that's, I think, quite confronting data to see. So we know most women in this sample reported not accessing healthcare to avoid negative treatment. Women who inject drugs for a range of reasons may face structural, social, and cultural prejudice and harms, especially if they are pregnant or they are caring for small children. Women may be less likely to access drug treatment or harm facilities, and their needs may often be specifically overlooked. Women who inject drugs are at a risk of acquiring BBVs and STIs, but barriers to healthcare may result in reduced screening, diagnosis, and treatment. So I think that's it, guys. So I guess all of this research, we can talk about ways to encourage and facilitate interaction with the health system in general, and how to make the ARD and harm reduction sectors positive environments for staff. So I'm happy to take any questions. I just want to show you that in this presentation, which we will, I'll provide to you after the talk today, I have listed the 2 publications that I've spoken about in the presentation, and a link to our website, which has lots of information on our stigma indicators monitoring projects, because, as I said, we focus on a range of priority populations, not just the ones I spoke about. And the last thing I just want to note, besides thanking everyone, is our conference, which is happening in November. It's the first Australian conference tackling stigma, overcoming stigma as a barrier to healthcare. And we have had 115 to 20 abstract submissions. I think it's going to be a really interesting program. So please try and make your way to Sydney for our conference. And that's it. Should I stop sharing, Michelle?
You can leave that there if you'd like to.
Like to add
and take note. Thank you so much, Loren, for sharing all of that work that you have pulled together and that so many people have generously contributed to. At the moment, we don't have any questions in the chat or comments, so it might be an opportunity for people to reflect on that last, I think, second last slide you put up, which was, just wondering about what we can do, ways to encourage and facilitate interaction with the health system in general, or what we are doing. And while people are thinking about that, because it is such a wonderful forum to be a part of, have heard all of that and be thinking of that. It might be that there's a lot to take in there, isn't there? There's a lot of hard things to hear. And as one of the people mentioned, a few things that stuck with me, if I might share those, is that stigma wounds, that's a really a memorable thing to hear, that stigma wounds, and that it's exhausting and disappointing. And when you might have worked in the area for some time, I know I have, for numerous decades, it is disappointing that we aren't seeing the changes that we would like to see and that we need to see to improve outcomes for the people we serve. And there's lots of questions popping in now, so that's great. I'm going to have a look over here.
I'll just note in the interim that we are hoping to publish from those quotes that I spoke about. So we're trying to produce a commentary because we got so much feedback. People were so willing to share in the survey, which was fascinating for us because we've never had that kind of response before. So we're hoping to produce a more kind of cohesive piece of work around that.
Oh, yeah, thank you for sharing that. That's something to look out for, isn't it? And yeah, that's worth noting, isn't it? That it seemed that opportunity to be heard and be listened to and to have that information taken up and elevated was a very important thing to the people participating. A couple of things I might mention. Let me just go back here. Put the website link again to the research. Maybe we could just put that up again in a moment. Here's a question from Lorraine. How do you yourself as an AOD healthcare worker respond to stigma with your role, Loren, given you're in this space? Big
That's an interesting question, Lorraine.
Have any things to share?
So I'm not a clinician, I'm a researcher, and I work in a research environment where that's what we work with, people living with bloodborne viruses. So it's what we do, and our aim is to make people aware of how much this impacts our vulnerable and marginalized populations. So for me, I find it empowering, and I find it really important to be able to put our research into the public domain. So these opportunities that's been like the one that's been provided today is really important because we don't want our academic research to sit in a vacuum. We want to understand people to understand that there are real consequences for people working in the sector, for people attending the sector, and how do we best create a positive environment for people who do the meaningful work, which isn't actually us, we're just researchers, but people who do that meaningful work out there. What's the best that we can do to facilitate that?
And it is very important that you're able to, this is important work. I just want to say, it is so important that there's a place, there's a repository for voices to be heard. I think I'll read you some of the comments that people are saying. I'll share it with everyone. But sometimes perhaps stigma feels like air, it's like invisible. And it's a really important thing to make it seen and heard so that we then respond and think about what we can do. I'd like to share some things that people are saying here. Just getting my processing going because these are jumping all over the place as people keep adding comments. That was brilliant, and I'm grateful for the work you have done on this area as an Aboriginal woman who comes from a disadvantaged background. I totally know what stigma feels like, looks like, and it does wound. That's from one of our participants, Lejos.
Thank you for sharing that.
Anita says pregnant women probably get it the worst. Lejos also said how to challenge our colleagues, to challenge anyone about their attitudes, how to change, how do we do better? There's other questions like that. are there top tips, maybe little sneak peeks from your interventions? I don't know if you're able to share any of those, but translating some of this amazing data into hopeful practice.
So I can put something out there. Asham has produced, I don't know if you've seen them, but Asham have produced short kind of micro-learning videos based on some of our intervention work. It's kind of got a social norms theory behind it, which is not, it's quite important in terms of the fact that it's these interventions are framed by people who work in the sector. And they are interventions aimed at a range of kind of priority populations as well. So I can find the link. It's just a short video. It's about the impact of stigma and what we do to try and mitigate that. And if you haven't seen those, I think that's probably a good starting place as well. Good to share. I don't think this sector needs it necessarily. I think this sector needs to be able to say to other sectors which don't appreciate the stigma that you guys face, they need to see these videos.
Well, thank you for, if you're able to share that, we might be able to pass that on as we put the webinar up, recorded, Loren. Someone else is saying, yeah, Tanya's saying, I think it's sad that those with lived experience have higher stigma, yet higher job satisfaction and are less likely to leave. Does that tell us that they've become more tolerant of experience the stigma, as perhaps they've experienced it for a long time? What do people say to you, Loren?
I think as I was talking about these quotes that came from surveys, I was actually thinking that we need to do qualitative research. We need to really explore these issues. That's the one thing. I think that that's a very good observation. I think that there's people with lived experience have experienced it themselves, and so they've probably become more resilient to it. I think also one of the things we found is that they experience less client-related burnout. And what this means is that they will have less, they don't feel as kind of worn out, for lack of a better word, from a sense that their clients are not responding well to treatment or improving, because I think they have a better understanding of the treatment journey, maybe having experienced that themselves. And I think that's a really important factor. In fact, we are going to be exploring this in a future project that has just started, which is a collaboration between us at UNSW and the University of Queensland. We have ARC linkage funding to explore the role of lived experience for people working in the mental health and AOD sector. So watch this space. There will be more to come, and we are about to do qualitative interviews that look at this in more detail.
Thank you. Yeah, someone else has said, they maybe also these people have a heart for their service users, that thing perhaps you were talking about, that notion there. Someone else said they didn't think they felt stigma. Then they noticed that they take off their hospital ID at lunchtime, as their ID states, I work in drug and alcohol. And I think it's interesting, just the things we might get from the presentation. Another thing I'd never really conceived of was being stigmatised as a total service. I'd just seen it on an individual level, but when you start to think broadly, yes, there's all these aha moments.
And I think it's important for the workforce, because I think there's a reason the services are sometimes isolated, because of the service work that's done and because of the clientele group. And I think clients feel that too. So I think all of these things need to be understood and acknowledged. And that's why getting the perspective of a broad range of people working in the sector is so important.
Indeed. Someone else has mentioned, the big task of the general public, the media, and just how big that is. But I wonder if you have any thoughts from your research about any things that we can think about or be doing.
I think it is really very difficult to address the general public. And I think that the general public, there's always going to be a sector that hold negative attitudes towards these particular groups of people, because we know that it's negative attitudes are associated with more conservative practices, and it's hard to move people who are conservative. So what interventions tend to suggest is going for those the middle ground, the people in the middle whose attitudes are susceptible to change. That doesn't mean we shouldn't try. And certainly I think we've managed to do it in relation to the LGBTQ communities. Attitudes have shifted over time. They're still obviously not great in some areas, but in our major centres, we have much more positive experiences for those groups. So dedicated campaigns at a national level, I think, are the only things that can start to reduce, and also acknowledging that stigma exists for all of us in all these sectors is a key to beginning the steps to reducing stigma.
So yes, acknowledging it, calling it out, seeing it, and it made me think of another thing, that when we're trying to shift cultures and we all sometimes are involved in different aspects of that, just on like a workplace practical level, something that I've tried and others is sometimes making it a standing agenda item as part of our meetings or as part of our supervision or whatever that is. And yeah, that's just another thought that came to mind, because it makes it visible. It makes it important enough to talk about what we do. Any thoughts from Dee? Does the stigma vary if service users are seeking to, oh, that just flashed away from me, to abstain rather than reduce, and looking at harm minimisation?
So we didn't specifically look at that in these studies because, one of our things is we want to ensure that the workforce define what they feel is best outcomes for the client. So I think that if we went into looked at different practices in more detail, we would find differences. I think there's a very different way people practice who have a belief that abstinence is the only outcome, compared to people who believe that providing a kind of harm reduction approach is the best outcome. But I don't actually know. We haven't looked at that in any detail.
Okay. Thank you. Someone else comments, Spencer, that they feel that often even connecting with peer workers in private spaces can seem difficult for some health workers, some clinicians, for fear of stigma and discrimination in a workplace. Yeah, that's disappointing, and yeah, it's important to recognise the ways it shows up.
I think for peer workers, it can be difficult. I think they need specific training. And I think that's where also it becomes blurry for people with lived experience who are working in the sector who are not in peer identified positions, because they might not be supported around having that past history of lived experience. So one of the things we also found in the mental health, in the research we did around mental health, is that it was difficult for staff, if they're not well supported, it's difficult for staff to know how much they should share with clients in terms of their own past experiences, because it obviously contributes to creating a better working environment for the person, the staff member, but how much do you share with the client, or or not share, is something that I think is also important to be worked out in a good supervisory situation.
Yes, indeed. There's a lot for people to navigate there, and to consider, to keep themselves feeling okay, and others. Yeah, there's a lot of love and lots of thanks for this. People are saying it's a heartwarming conversation. It's good to be heard and seen. And they're also reiterating a lot of the things that you found. So they're echoing all of those things, and often feeling like their role as lived experience worker, or the sector, the AOD sector that they're in, seen as a lesser field. And people say, when you're going to get a real job? And it's yeah, it's lots of hypotheses around why that might happen. There is a question about the conference, and is that going to be online? Can people access that in any way?
So unfortunately not. I think we will put our keynote speakers online. It was just too difficult for the first time, and too expensive, too costly to run hybrid, unfortunately. So our first round won't be, but potentially in the future we will run hybrid conferences.
Okay, great to know. And that sounds like an exciting conference. It might be almost time to wrap up. There's also some comments about how we're all working on this, that all of us come with differing biases, and so it's really important to have time to reflect on ourselves and our practices, and to have the chance for supervision, and to see how we can become better, can keep being better at this, keep thinking about this with reflective practice. There's heaps, yeah. So there's I think I've gotten to most of compassion and courageous conversations are key. Yes, thank you, Lajos. And I think it does take, should it have to, but it does seem to take bravery sometimes, and that's sometimes hard. Especially when we are scared. And I think that's one of the things that I thought about, that fears often maybe why there's, because this can be any of us, and it's all of the people we know and all of society that might experience substance use issues. Maybe that's sometimes why we experience that stigma in the systems we work in, being the lesser cousin, being the... I think, would you like to finish off with any top tips or takeaways, Loren? I'd like to thank you as you think about that, and let you know that there's been a lot of gratitude for what you shared, and the forum to discuss people's views.
So can you still hear me, or is the mic gone a bit funny?
It's come back. It went a bit weird, and now it's back.
So
Sorry,
I just
everyone.
want to say that there has been, I did present a lot. There's been probably a lot to digest, as you mentioned, Michelle. So people can email me. Feel free to email me. I didn't actually put my email address in here, but I'm easy to find, and you can email me with any questions. And anything you want to know about any of our reports or publications, please email. And please share. We want to get this research out there. And interestingly enough, we thought of this research, of the idea of doing this research, which particularly the stigma by association, which we didn't have much funding for, because we've heard anecdotally that people working in the sector experience this. So we really wanted to highlight it. We thought it would be important. And now we can build into more research from this, which will be the ARC linkage work that we'll be doing starting next year. So look out for us and our work, because we wanted to feed into policy and practice.
Oh, fantastic. Thank you, Lauren. And we've got people saying they want to be a part of the next round of research.
Excellent.
Got a team in AODS at Canberra Hospital putting their hand up. So just letting you know.
Great.
So thank you so much for today.
Thank you for the opportunity.
For a wonderful presentation. And I'm sure you'll hear from some of the people. It's good to be connected in this space. Lots to go and think about. I'll just mention that next week we'll be back here at same time, same place, next Wednesday. And next webinar's title is Australian Consumers' Experiences of Long-Acting Injectable Buprenorphine and Implications for Clinical Practice by Dr. Tony Barnett. So we hope you can join us then. Thank you for coming along today. Thank you again, Lauren, and thank you everyone for participating and sharing your thoughts. And see you next time.
Thank you.